biohacking your own estrogen while you're on testosterone replacement therapy. This also goes for steroids too, guys. This is such an important video because I've done other videos on testosterone and estrogen and aromatase inhibitors and all this stuff. I'm going to include all that here. But in my medical practice and for years looking at men taking steroids and testosterone, it's amazing that beyond the health consequences that men suffer with and can have side effects, they are so concentrated and focused and obsessed with estrogen. We get calls all day long to Nurse Wendy and Kim. I gotta talk to the doc about my estrogen. Something's wrong. I don't feel good. Well, what is it? My brain fog. I'm losing money. I don't know what's happening. I can't focus. My wife's mad at me. I'm moody. I'm irritable. Of course, then we go into gynecomastia. There's sexual issues. So let's hit a reset button, guys. Let's really go into the science of this clinically. So estrogen, by the way, is not bad for men. It's needed from the brain to the sex, not to mention muscles and strength. But balance is the key. Understanding the relationship of androgens, not to mention exogenous androgens, taking it yourself. This is not for endogenous. This is not for men that are getting older. Maybe they're a little overweight and they have an imbalance of testosterone and estrogen. That's important, but this really is all about, you're on TRT, what do you do about the estrogen from the scientific standpoint? And the clinical standpoint is I have all this experience transferring to you guys here. So men create estrogen because they have endogenous testosterone and or exogenous, those are the injections, the creams, the pellets, even the pills. And it converts to different degrees of estrogen because we have an enzyme throughout our body called aromatase. That's this conversion, right? So it's happening all over the body. Where does it happen? It happens in the central nervous system, that's the brain. We know that. It happens in the testicles, interestingly enough, the blood vessels, the liver, fat, bone, and of course skin. You see that? It's happening all over the body, guys. The predominant form of estrogen is called estradiol, or E2. Let's talk about the systemic breakdown in the target organs that I just went into. Let's take it from head to toe. The CNS, that's the brain, guys. That's, again, the moodiness, right? So this is so important. The sex, the moodiness. It's really not happening so much in the penis itself. All this stuff is happening in the brain, the central nervous system, because of the drugs, right? Because of the testosterone. It can be great. And it changes and you lose it. You want to get it back. So the CNS, the cognitive aspect, the thinking, the focus, the mood, the ups and downs, the good mood, the sex, the libido. And sex is very complex for people, but this is for men. For women too, though, it's very interesting, right? Androgens, estrogen, balance. So it's libido, the thinking of sex. You're sexual, you're horny, you're interested in sex. And then it's the physical erections. There's a lot going on there. Let's keep going. Next would be the skin. Everyone's going to think about the skin, think about acne. Now, acne's complex, right? It's not just extra estrogen. It's related to a lot of genetics and other issues. Androgens itself, DHT conversion, not to mention other steroids. There's so much interplay here, guys. The genetics have such a role. There are men that really can't take testosterone, or it's very difficult because you can't live on Accutane forever. And if you do, you got to be very careful with it. I have a lot of experience with this. Now, the next piece is going to be the classic gynecomastia. There's two types of gynecomastia, classically. There's the mass, where you have this physical mass and it looks like you have little boobies. And the next thing is called sensational. And only unless you're on testosterone and steroids, you're never going to know this. Everyone's going to think the physical mass. He's got gyno, he's got bitch tits. But you know what's really more common is that you take testosterone and you get this irritated, burning, painful sensation. Not just when the shirt's rubbing on it, or law enforcement guys, they wear the vest, or hunters or people that wear a vest. It irritates the nipples. So I deal with this every day, guys. Very complex. You can't just give anti-estrogens. Okay. Next, the bone and the musculoskeletal system. So estrogen, blocking estrogen, right? So guys, I'm going through the systems. If you block too much estrogen, for an example, when we use aromatase inhibitors for women, they're for breast cancer, we have to be concerned for osteoporosis. Now, that's not going to happen for young, even middle-aged or older men that are on a little AI. So it's really not, are you really going to have osteoporosis and hurt your bones? Well, if you deplete and crash your estrogen and you're on it long enough, you will. But you're on androgen too. That's stimulating the receptors in the bone. That's anabolic to bones, and not to mention muscles. So let's go back here a little bit. What's happening with that? Estrogen. When you look at the strongest men in the world that I've cared for, big strong guys, the strong men, world's strongest man guys, 300-pound, 400-pound men. Those guys, you think they're estrogenic? 20 years ago when I started doing this, no names mentioned, top guys in the world trusted me. I met them. How you doing, sir? It was unbelievable. These guys are monsters. I was like a kid in the candy shop because I love strength guys. And I'm looking at these guys and I'm looking at their estrogen because they're on tons of testosterone. Well, maybe a gram or so. Not that much, I guess, in the big picture. A gram when they're training, competing. And they like Anadrol, Dianabol. These things are estrogenic. And I was like, wow. I was looking at the numbers because I did the labs. These are guys right in front of me. They come in to see me in America. How's your estrogen, sir? Look at this. How do you feel? Oh, God, I don't know, doc. I feel pretty good. But, I'm all over the place. I'm moody in this. But they're not living on this kind of regimen full year. They're blasting and cruising, guys, right? So, but when I looked at the estrogen, it was off the chart. And these guys were not using aromatase inhibitors because they told me just anecdotally that doc, it's bad for the joints. And these are smart guys. They're learning in the streets, but they're not science guys. They're really, some of these guys were, some of these guys are. You guys are super smart. And there's even some doctors in the picture there. So PhD doctors mainly, and science guys. And they were like, doc, you really don't want to block with aromatase inhibitors because, man, you'll rupture a bicep tendon, tear a pec, your legs, your quads. Wow. So here's these guys that are the top in the world, strong guys, and they're puffy, they're estrogenic. Even their sex was pretty good. And I was like, how can you even have sex? I couldn't believe it. So that's the musculoskeletal. You have to biohack your own stuff now, guys, using systems approach. Let's keep going. Next one is just systemic edema. I told you, the guys are big and strong. They get like puffy heads, right? You see, man, the guy's head's like a watermelon. Well, he's puffed up. Estrogen, testosterone, just puffiness, overall systemic water retention. And that leads to the heart stuff. So let's go to the heart next. Again, this is what happens when you're on androgens, depending on the dose, who you are, what drugs, how estrogenic you are, your baseline, and what's going to happen systemically with estrogen. And you can measure it. We're going to get there. So moving into the heart, this is arguably one of the most important pieces, that in the brain and the sex, right? So coronary artery disease, myocardial tissue itself, the heart tissue itself, the electrical system, and the lipid system, right? So this, I could talk for like 6 hours. This is the stuff I do. So when you look at estrogen, we have no direct data for this, but it's so indirect that women, when they're Before menopause, their bodies, which is multifactorial with their estrogen from their ovaries, there's definitely some protection from them for them. And when you start blocking estrogen for them, when they have breast cancer with AIs, there's definitely even a black box warning that you have to be careful with coronary artery disease. You see, because it's going to affect the HDL. That's protective, and you're going to really affect that. It's going to decline. It's going to be reduced, and you're going to lose theoretically some of that protection. You see, guys? But then the AIs and blocking estrogen and having a little estrogen, we feel just clinically is probably somewhat protective for men. But again, this is man per man, and you really have to understand all this stuff, for who you are and what it's doing to you. Next, the hypothalamus pituitary gonadal axis, kind of more for like looking at that ratio of androgen to estrogen for natty guys. Relationships to TRT and steroids, it is interesting how much that's going to shut you down when we start looking at tamoxifen and Clomid with HCG, when you're looking at post-cycle therapy, guys, kind of beyond the scope of this video, but all this stuff is just related together. So complex. So the last system here as we go head to toe is the prostate system. Let's talk about two things that are going to be very concerning for any man, not to mention if you're on androgens. The BPH, benign prostatic hyperplasia, that's going to grow through the prostate itself. Man gets older, it's a natural process. It can be deteriorating. It can lead to obstruction, urinary tract infections, sexual dysfunction, and very annoying. It's just very, very annoying. Now, that's a natural process. Estrogen is definitely part of that. And this ratio, too much estrogen, question mark. Yeah, what do you do about it? And the dangerous pieces, which is, thank God, this is prostate cancer. Androgens are not directly linked that if you take androgens, you're going to guarantee to get prostate cancer. That is not true, but I'm not going to go into all the data for that. We have to watch that. And if you have prostate cancer, say you're a man in your 50s or 60s and you have a small prostate malignancy in your prostate and you give it exogenous androgen, whoo-hoo, boy, I've seen it. It will grow it, and then you'll see the PSA go up. You'll find it. And then what do you do about it? Well, I deliver all those to urology, full-blown experts in the prostate, and I just stand back because I'm an internal medicine doctor. But I've brought out a lot of prostate cancers because I've given testosterone, and then we see the uptick in the PSA. You don't feel really anything. No one's going to really feel. The data supports this with a digital rectal exam in the beginning when that PSA is going up and you're growing a small malignancy in that prostate. There's no manifestation where you're going to feel it physically. Very unusual. Still have to consider doing it, and I hand everything to those experts, and then they're going to go for prostate MRIs, potential biopsies. I leave it to those guys. So that concludes the systemic effects head to toe on what's going on with your estrogen on testosterone. Let's move on to the rules now of how to maintain and understand this and control this. This is what you get with the Anabolic Doc app. Number one, a digital history and physical exam, where I bring you through digitally all the important medical issues that you need to understand one by one. Number two, weekly Zoom meetings with me. They're group meetings where men come from all over the world to ask questions, and I answer the question, everyone listens and learns. Number three, discounted commercial labs. The actual lab panels that I order for my patients, discounted only through the app. You have access to these labs all over America. Number four, weekly member-only uncensored videos. This is really cool content that I can't make on YouTube or Instagram because a lot of circumstances, I'm talking about protective medications like blood pressure, cardiac medications, and I can't mention brand names. Here, I mention everything, fully uncensored, so you know exactly what to do. Number five, Anabolic Doc's mailbag. you can't come to the meetings or you don't want to come to the meetings, you ask a question. I'm going to respond to your question by making a video, put it back up on the app, and you get to see your own question by me as a video. Lastly, diagnostic and management library that is easily searchable by keywords. I've put all this together for you guys for $19.99 per month. Come to one man-to-man meeting. Let me answer your question. Look at the videos. Do a mailbag. Order some labs for super cheap. Really get into your health. Guys, I've done this for you to scale what I'm doing for men to protect you on androgens. Give me a chance. Rule number 1 is understanding the pharmacology of testosterone aromatizing to estradiol, looking at it with TRT and different doses and into steroids, because steroids, the difference, a lot of people don't know this, is that the difference between the steroid and testosterone is dose. If you're looking at testosterone esters, you just take a lot more of the testosterone and it becomes a steroid, super physiologically. And there's tons of other steroids, NOR19 steroids, there's DHT-derived steroids, and there's testosterone-based steroids. And this is a whole nother gamut. And then you look at the propensity for the steroid to aromatize. But this is going back right now to essentially aromatizable testosterone esters, propionate, cypionate, enanthase, sustanon 250, and even undecanate, long-acting, either the pill or the long-acting injection. So now, the type of estrogen is E2, estradiol, and what you want to do when you're looking at this pharmacology is understand the timing. If you inject testosterone, say 0.5, right, my dose every 5 days of 200 milligrams per milliliter of cypionate, so it's 100 milligrams, you inject it. And if you go to the lab within 12 hours to 36 hours, the free testosterone's peaked and you're gonna see a much higher ultra-sensitive estradiol. And that's what you wanna get, the ultra-sensitive estradiol. Talk about that in a minute. So when you have to understand the spectrum of the pharmacology. And if you wait days later, every day, theoretically, when it hits the peak, which is going to be very complex with the mathematics and the individual biochemistry, but typically within the first 2 days. And then after, if you're injecting every week, I mean, if you check your estrogen at the end of the week, right before the injection, it's called nadir, you're going to see it's going to be much lower. So are these numbers helping you? Guys, think. Is it what? That's my estrogen. No, that's your estrogen at that exact time after the injection. How many hours with that dose, with your biochemistry, with other drugs? And guys, you have to really put the thinking caps on and number. No, what's the number? But what's the number before? What is it after? What are your clinical symptoms that I just talked about? Okay, I want you guys to understand. You don't want to get a total estrogen. Never get total estrogen. It's contaminated. Just believe me, it doesn't mean it. I've looked at these years ago when I was making the mistake. And I saw total estrogen. I used to order it all the time. Total, I want to see all the estrogen. It's mainly E2, but I want to see them all. And you get that, you order that lab assay test, and then I was giving guys, I was seeing up to 714 numbers that didn't make sense. I'm giving not just anastrozole, I'm giving letrozole, I'm giving all, and the guy's like, I don't know, doc, I feel like shit. I don't feel gyno anymore, but I feel like, but my estrogen's up because they're treating a number. And I realized, I called the LabCorp and Quest clinical directors with PhDs, even got into a little fight with a guy because he was busting my balls like, what are you doing measuring these with men? Like I'm pushing steroids. I was like, sir, shut up. Give me the answer on this. I want to know the scientific answer. He's the lab guy. He's a lab geek. He told me, no, everyone knows. You never measure a total estrogen. They're useless. Why are they useless, doctor? Because they're contaminated. They cross-react with other constituents. Boom, done. Never get a total estrogen. In your country, wherever you are, you want to get something called ultra-sensitive estradiol. And it's a liquid chromatography mass spectroscopy, MS. It's run on a very special methodology. The one in America that we use most commonly, however, there's many, is the one that you see less than 29 picograms per mil is normal. Bottom line, when you're looking at a nadir dose or just post-peak, past the peak of your testosterone injection, I don't mind guys going up to around 30s or 40s because they feel great. That's information I just gave you guys. Really, I don't think anyone else has really seen this. I've seen this with thousands of guys, but it's got to be man per man. Let's keep moving. Rule number 2, think sustainability, guys, like I just said. Is it TRT? Are you on a blast cycle? Are you on steroids? You managing estrogen via the testosterone delivery system. You want to understand that sustainability is key. Microdosing is key. Lowest effective dose. Area under the curve. I'm giving this stuff to you guys because you have to understand, where are you at? Where are the numbers? Is it right after the injection? Are you on a cycle of Dynabol? Are you taking aromatase inhibitors? Are you down? Are you crashed? How do you feel? Guys, look how spiritual, look how complex biohacking for your own estrogen just can be. You have to understand this thing from a really bird's eye view looking down and understand sustainability. That's why I want you guys to take the lowest effective dose, understand delivery from the skin, from the pill to the microdosing to a big injection that your doctor gives every 2 weeks, every week, or every day, every other day. Can you do it? That's going to affect your estrogen. This is so complex, guys. Okay, let's move on to number 3. Rule number 3 is about anti-estrogens. This is the stuff you guys really want to hear now. You understand the clinical, your individual needs. You want to now move on that maybe you're going to use some medications. Let's talk about that. Here are the anti-estrogens. You want to use them sparingly and take breaks. You want to think about the classic is the gynecomastia, a mass versus sensational. Let's go into it. So it is true, guys. I do prescribe aromatase inhibitors. The most common one is anastrozole. So let's just talk about that for an example. It's 1 milligram tablet, typically cut it in half. You can even go less, okay? And you can take it once or twice a week, typically right after the injection at 24 or 48 hours. Okay, now, when you look here, you're going to see that when you use aromatase inhibitors like anastrozole, and there's other types, right, of AIs, it's really for both reduction and prevention of the mass and or sensational gynecomastia. That's very, very complex. So when you move on to SERMs, selective estrogen receptor modulators, both tamoxifen and raloxifene. Okay, now I have the doses here for a minute. I see it, they're much better, and you got to be limited with these, limited use. And it's last resort use. You've already tried to microdose, you've cut down, you've done everything else you can, but you need a little bit of this from relief, mainly from the gyno. And it's more sensational. I let my patients use it. I prescribe it very cautiously. It does work. Guys will use it maybe a couple times per year. You see, that's my guys. So that's why I see that SERMs, tamoxifen, raloxifene, I'll go into those in a minute, the doses, that they're much better for sensational gynecomastia because the data shows that you're really not going to reduce the mass. You see that? And if you're using them that much, you got to stay on them so long, not to mention from the beginning. Imagine the side effects, even DVTs. It's no joke, guys. It's really no joke. This is why you have to biohack your own. Keep the doses down. Understand your numbers and your symptoms. And then you have to come to the anabolicdocapp.com and ask me questions. This is why I'm transferring my information to the app for all you guys, because I have my patients and I love my patients, but I really can't take any more. So back to the AIs, guys. The AIs can be used. Again, very small doses. It's so easy to crush your estrogen. And if you're at a facility, a clinic, or someone's telling you to take like 1 milligram, every other day or twice or 3 times a week, you're going to see your estrogen's going to be like crushed. And that's not good. And then is your brain bad? Is your concentration bad? Are you flat? Is your sex bad? And then imagine your HDL, what's going to happen potentially to your heart. Remember the power lifter. Remember the heavy duty guys. They didn't want to touch that stuff. Okay, back to the anti-estrogens. Tamoxifen, typically 20 milligrams, once or twice a day. I like it once, maybe 2 or 3 days for sensational. Doc, it's burning, it's irritating, everything's down as low as I can. I get the sensation a little bit, and I want to try to just hit a reset button. Not more than 2 weeks. Right there, tamoxifen, 20 milligrams, once or twice a day. I like it more once, keeping everything to a down low, 2 or 3 days in a row, but voila. Again, not for the mass. That's the AI from the beginning, but oof, guys, this is complex. Raloxifene may be better than tamoxifen. It's really the same drug class. It's kind of interchangeable. 60 milligram doses typically daily, once a day. Again, and again, same as tamoxifen, 2 or 3 days, maybe 2 or 3 straight days, maybe 5, maybe even more than a week, definitely not more than 2 weeks, and then hit a reset button, change your protocol, talk to the doc, come to the app, come to the meetings. Okay, now, other ancillary steroids to control estrogen. This is huge information I've learned from so many of you brilliant guys. When you look at DHT class of steroids, Proviron, Masteron, Primobolan, these really can be working with estrogenic steroids as anti-estrogens. I have videos on this. It's fantastic. Guys, this is the future. And I'm not advocating steroid use. This is an advanced video for guys that are on TRT. We can't even get these medicines. We're not getting Masteron and Primobolan and CVS. But I've seen so many thousands of men where they're easy. When I say easily, it means they're utilizing very low doses and they're not living on it forever, but they use these with low doses. This is TRT. This is not full-blown competitive steroid guys, bodybuilders and pros. And this is not related. This is like sustainable life, to live as long as you can and just feel great and modulate your own, biohack your own estrogen. So the next step in the modern world, is going to be absolutely carefully using some of these other DHT-derived androgens for their anti-estrogenic properties. This is a secret, guys. The video's worth is right here, I think. Thank you, guys. All right. Now, when I have area under the curve of the steroid side effects on the heart, hematologic system, that's the red blood cell stuff and that androgen-induced erythrocytosis and the red cells, guys, the red blood cells, and that iron potential with the ferritin. You guys got to be careful. And the effects on the kidney, the prostate, DHT derived. I know estrogen can be a problem. Too much estrogen for BPH. Guys, I know this. This is my last frontier, if you will, of my thinking. For the heart, I got figured out. That's pretty easy. It's maybe a lot of medicines. It's complex, but I got that figured out. ABCDs. But when it comes down to this stuff, the prostate, the estrogen modulating, biohacking, this is going to be like super complex. And I think in the future, using these DHT-derived drugs concomitantly with low-dose TRT is the key. But there'll be side effects of hair loss, maybe side effects in the prostate and your sex. And then you get down-regulated on this and you have to hit a reset button and come off it and change. Come on, guys. This is complex. So again, on the brain, the prostate, the kidney, the red blood cells. That's why that area under the curve, guys, you want to keep that to a down low. On May 26, at the Upgraded Human Mastermind event, Plano, Texas, I'll be speaking on modern androgen therapy, the history of modern androgens, the spectrum of utility from testosterone all the way through to PEDs, understanding the necessary harm reduction, the androgen markets and future trends, of course, clinical application for both men and women, understanding risks, side effects, and of course, the future of androgens. I've been caring for men on androgens as an internist for over 20 years now. Please buy tickets and come out and see me and all the other great speakers at www.plano.com. upgraded human mastermind live. Thank you. I'll see you there. Rule number 4 is my old school monitoring the ABCDs. Now, that's the hemoglobin A1C, B is blood pressure, C is cholesterol, D is deposition disease, also depression. The deposition disease is the red blood cell stuff. I have tons of videos for that on you guys, and we always talk about that on the man-to-man meeting and the Anabolic Doc app. So you want to come to the app and you want to access my information and have access to me for questions. And S, ABCDs, and S stands for screening from skin cancer, eyes, colon cancer, prostate cancer. Again, and S stands for PSA, prostate cancer, and S also, again, for serotonin for depression. With the ABCDs, guys, it covers everything. Next, men that are overweight and have more body fat, they have more estrogen. Please understand that. It's good motivation to be lean. Guys that are super lean, they take even estrogenic steroids, you definitely see less conversion to estrogen. Fascinating. So whole food, eat clean diet, limit alcohol, high intensity interval training, cardio, DIM. This is super amazing. DIM is a natural supplement that I just want to have everything for you guys here that can block estrogen. I like real medicines that I can control. I like the quality and that I can control them. Because when you buy supplements that are supplements, they're supplemental, and the quality could be great, you don't know. It's up and down, right? It's not regular. But hey, DIM is there. Zinc, creatine, calcium D-glucarate, grapeseed. I'd want to give everything. I did a lot of research for this for you guys. For all the guys that really don't want to use too many medications, these are the supplements that can be utilized. But I think losing weight is not talked about enough, and having a great tight diet. And the last piece is number 5, breast mass. You got to see a surgeon, and potentially even a plastic surgeon to get the gyno surgery. It's really at the end of the day, if the estrogenic components for you are because of gyno, either sensational or the mass, everyone knows in the end you can go to a plastic surgeon, not a general surgeon. But when you have a breast mass, I have to worry that it's breast cancer until proven otherwise. This is really for doctors. We have to be careful. And it's just, oh, come on, doc, it's not breast cancer. I've never seen one case of breast cancer on steroid men or a man on testosterone in my life, 20 years now. But what about that one guy that's out there that happens to have breast cancer? Because men do get breast cancer. It's about 1% of all breast cancer cases are men. 1%. That's a real number. It's gambling, right? It's just lottery stuff. So whenever I hear a man with gyno, I always have to cover my base and him and say, sir, you need to go see a breast surgeon. It's going to be a general surgeon. You don't need plastics for that. But in the end, if they're going to do surgery, I don't want to see a general surgeon do gynecomastia surgery, because I know it looks like ice cream scoopers, that it's scooped out and then the nipples are invaginated. It looks horrible. I'm not saying some general surgeons can't do a good job, but why are there gynecomastia plastic surgeons? If you have a facelift, you don't want to go to a guy who just does breasts. And a guy who just does breasts is not going to do just the face. And if a guy who does both, be careful. Maybe the guy can, but I'm a specialist. All right, guys, that's it for this video. Give tons of comments, because all the men in the world learn from each other. And please, you guys, I want you to stay strong and healthy. And that's why I transferred all my information and all my intellectual abilities to the anabolicdocapp.com. Thank you so much, guys.